Hello everyone, I'm Rafael Madero. I'm one of the chief residents at Mount Sinai Morningside West. As part of our Hemonc Emergencies curriculum, I'm going to give you a very brief overview of increased intracranial pressure secondary to malignancy. So metastasis occurs in up to 20% of patients with malignancy. It is most commonly caused by lung cancer, breast cancer, and melanoma. Prognosis really depends on the primary tumor, the functional status, and presence of systemic disease. Prognosis will guide treatment. Of course, you're not going to be equally aggressive with treatment with a patient that has a prognosis of a month versus one that has a prognosis of 12 months. The increased intracranial pressure is secondary to the primary tumor as well as the surrounding vasogenic edema. There are multiple reasons why this edema is caused. One thought of reason is the disruption of the blood-brain barrier. Um, Now, what is the emergency? It can cause significant neurological injury and it does require prompt identification and treatment because it can be life-threatening. And brain lesions usually also have a significant impact on prognosis. So for the clinical presentation, neurological symptoms really are going to depend on the location, the size, and region of the brain where the lesions are located. Headaches are obviously the most common presentation. Some of the typical characteristics are that it worsens with leaning forward and also with Valsalva maneuvers. The most typical presentation is characterized as a headache that presents in the morning and improves throughout the day, though it's only present in this specific manner in the minority of patients. It can also be accompanied by nausea and vomiting as well. It can also cause hemorrhagic strokes if the tumor bleeds. Some tumors are more prone to hemorrhaging than others, such as melanoma, choriocarcinoma, RCC, and thyroid cancers. And seizures can occur in up to 20% of patients. We're all familiar, of course, with Cushing's triad. It's the presence of hypertension with white blood pressure, bradycardia, and irregular breathing. Though this is a very late sign, and it is a sign of really impending brain herniation. So really, you should not wait until you see these symptoms to identify it. As part of the workup, really, of course, you need a very good neuro exam to identify any particular um, effect that the mass might have, and even to identify a change in neuro exam in a patient with known um, oncological malignancy should really raise flags. So you should really do this if your patient, is presenting with a headache and you have a known history of active cancer. You really, as part of the workup, should get an MRI of the brain with contrast. This helps better identify or distinguish metastatic lesions from other type of primary brain lesions. However, if you're suspecting hemorrhage or hydrocephalus, really you want a CAT scan because that is a lot faster than MRI. And if you have an unusual presentation for a brain met, you might require pathological confirmation. Imaging might not be enough. And this is just a summary of the management. Basically, I tried to summarize and split it into interventions. The main treatment, of course, if you have neurological symptoms and presentations, is glucocorticoids. As mentioned there, the indication would be symptomatic patients and in some edematous lesions right before radiotherapy. There's different dosing. Dexamethasone is preferred, carries a lower rate risk of infection and less pronounced mineralocorticoid effect. So the initial dose can be 10 to 24 milligrams IV, and maintenance is 4 milligrams IV every 6 hours or 8 milligrams twice daily. Um, Mannitol and hyperventilation, it's only reserved for severe cases of elevated intracranial pressure. It is fast acting but temporary. Um, and there are other options such as radiotherapy. Whole brain radiation is usually for multiple tumors or tumors that are too large for other interventions. And part of the reason for this is that whole brain radiation is actually associated with irreversible cognitive dysfunction in patients with long-term survival. So you really want to give it only when indicated. And Now, you also have the option of stereotactic radiosurgery in patients with few lesions that are smaller than 4 centimeters in dimension. In regards to surgical resection, it depends on the location and the number of lesions. You should really have neurosurgery on board early on. In terms of chemotherapy, it really does depend on the prognosis and the sensitivity of the tumor. It is usually better with agents that penetrate the blood-brain barrier adequately. However, this does not mean that you're gonna choose an agent just because it can penetrate the blood-brain barrier. Uh, there have been other studies and intricacies really in terms of chemotherapy, whereas just the presence of the tumor might disrupt the blood-brain barrier. So agents that might not have penetrated initially in the presence of brain mets might have slightly better penetration. And another thing is, of course, just because they have systemic sensitivity doesn't mean that the brain tumor that grew despite treatment is going to be sensitive to that agent as well. It's actually pretty interesting, but we can't delve too much into it in this brief overview. Just thought it was interesting. And in terms of anti-epileptics, you really give them only to patients that have seizures. It does not have any benefit proven as a prophylactic medication. You can also give it for a brief period of time in the post-operative period after resection of the lesion. And so take-home points, just keep a high degree of suspicion in patients with malignancy and suspicious presentation, work it up. Management is tailored to the patient. Not all patients with brain lesions have an equally poor prognosis. So if you do identify them, actually start having, a conversation with an oncologist. And if this does have a very significant impact in your patient's care, you might want to get palliative care involved as well. But this really should trigger all this comprehensive management and involving multiple services, including, like we said, neurosurgery as well. And these are just some of the references that were used in making this presentation. If you have any questions, feel free to reach out to me. I'm more than happy to help. Hope this actually is useful for everyone.